All right, let's talk about necrotizing fasciitis. Now, if you're gearing up for your finals, this is one of those topics you have got to know cold. We're talking about a high-stakes, time-critical emergency where what you do and how fast you do it can literally mean the difference between life and death.
So here's our game plan. We're going to start with the absolute basics, what this thing actually is. Then we'll get into the different types, how it wreaks such havoc, the all-important race to diagnose it, the pillars of treatment, and finally, we'll zoom right in on your specific role in the hot seat as the anesthetist.
Okay, let's get right into it. First things first, what exactly are we up against when we hear the term necrotizing fasciitis? When you look at this definition, there are a few words that should jump right out at you: progressive, fulminant, and rapid. This is not some slow burn infection. It's an absolute wildfire tearing through the deep tissue, racing along those fascial planes, and basically just destroying everything in its path.
And let's be crystal clear about just how serious this is. We're looking at a mortality rate of around 25%. That's 1 in 4 patients. This is a truly devastating condition, and it's why every single decision, every minute that ticks by, is just so critical.
And this is the single most important thing to burn into your memory. It's not just about what you do, it's about the speed at which you do it. Any delay in getting that patient to the operating room for surgery is the #1 predictor of a bad outcome. Time is everything.
Okay, so let's move on to classifying the infection. Because you see, not all necrotizing fasciitis is created equal, and knowing the bug behind it has some pretty big implications for treatment.
Now, this table breaks it all down for us. You can see 4 main types. For your exams, you're really going to want to focus on types 1 and 2. They're the most common ones you'll see. Type 1 is what we call polymicrobial, so a nasty mix of different bugs, and you often see it in patients who are immunocompromised, like those with diabetes. Type 2, on the other hand, is usually caused by just one organism, group A strep, and it can hit perfectly healthy people. It's also the type that's linked with toxic shock syndrome.
So how in the world does this infection cause so much damage so incredibly fast? Getting your head around the mechanism is really the key to understanding all the signs and symptoms that follow. And this picture tells the whole story. The infection doesn't start on the surface. It starts way down deep in the subcutaneous tissue and the superficial fascia. And that's why this disease is so sneaky. In the early stages, the skin on top might look totally fine, maybe a little red, but it's hiding this absolute catastrophe that's unfolding just beneath it.
It's this awful 3-step chain reaction. First, the bacteria get in. Then, they start pumping out toxins. These toxins cause tiny blood clots to form in all the small vessels that feed the area. And once that blood supply is cut off, you get ischemia, which leads to massive tissue death, necrosis.
Which brings us to the million-dollar question, doesn't it? If the early signs on the skin are so misleading, how on earth do you catch this thing before it's way too late?
Okay, everyone, lean in. If you remember just one single thing for your exams and for your practice, make it this: a patient who is in excruciating pain that seems completely, ridiculously out of proportion to what you can see on their skin, that should set off massive alarm bells for necrotizing fasciitis. The most common trap people fall into is misdiagnosing this as simple cellulitis, but they are worlds apart. Cellulitis is superficial. Necrotizing fasciitis is deep. With NF, that severe pain is an early sign, while the things we usually associate with a bad infection, like blistering, well, that's actually a late sign. Now, to give you a more objective tool, we have the LRI&E score. It's a scoring system that just uses 6 very standard blood tests. A score of 6 or more should make you highly suspicious of NF, and if it's 8 or higher, it's very likely. Think of it as a valuable tool to back up your clinical judgment when things aren't totally clear.
But, and this is a really important but, while scores and scans can help, they must never ever delay definitive action. The absolute gold standard for diagnosis happens in the operating room. The surgeon makes an incision, and if they see gray, dead-looking fascia, no bleeding, and they can just run their finger through the tissue planes, that's it. That's the diagnosis.
So the diagnosis is confirmed. Now what? The management is nothing short of an all-out assault on both the infection and the chaos it's causing in the body.
Treatment really rests on 4 crucial pillars. 1. Aggressive resuscitation with fluids, because these patients are in deep septic shock. 2. And this is the most critical, urgent, radical surgery to cut away all the dead tissue. 3. Powerful broad-spectrum antibiotics. And 4. Full supportive care in the ICU. But remember, surgery is the absolute cornerstone. Without it, everything else will fail.
And this brings it all back to you, because when this patient is rushed to the operating room, you are right there at the sharp end of the spear. So what are the key things you need to be thinking about?
Here's your high-yield mental checklist. You are managing a profoundly septic patient, probably with multiple organs already starting to fail. You have to anticipate enormous fluid shifts and potentially catastrophic blood loss from the surgery. That means you're preparing for aggressive resuscitation, with invasive monitoring like an art line and a central line in from the get-go. And you need to be ready for the long haul. These patients almost always come back for more surgery.
So that's really the fundamental question you have to ask yourself. When you get that emergency call, your brain needs to immediately flip into this mode. Severe sepsis, a crashing patient, and a massive surgery with a completely unpredictable course. Being mentally and physically prepared for that scenario is everything.
And for your reference, this whole review is based on a key paper from 2012 by Davodian and Flint. You can find it in Continuing Education in Anesthesia, Critical Care, and Pain. It is an absolute must-read for your exam prep.
And so we'll leave you with this final thought. In a condition that is defined by a desperate race against time, what is the one single factor that you can influence that will change the outcome more than anything else? As we've seen, it's the time to that first surgical cut. That is the key takeaway.